Is Gagan there?
Dr. Kavita, she's not there.
Gagan, Dr. Gagan.
No,
Dr.
one more
Kavita
doc.
will not be able to join us.
Okay,
She informed.
okay.
Dr. Gagan, I'll try and send a message, but meanwhile, we might start off.
Okay, doctor.
You can start off with the first video. Who's
Okay.
presenting it?
Dr. Shiva Yogi. Shall
Oh,
I
he's
wait?
okay. Okay, let me introduce Dr. Shivayogi. He's a young, dynamic oculoplasty surgeon trained by Dr. Usha Kim from Madurai. He's practicing in the place Davangere, and he's doing a lot of work, and including, I think his wife is a dermatologist, so he does a lot of cosmetic work as well. Over to Shivayogi.
Good afternoon. I thank QoS and the Chairman Scientific Committee for giving me this opportunity to talk on surgical management of ptosis. Ptosis is a procedure where you should know the anatomy of the upper lid, anatomy of the levator palpebrae superioris to have a good outcome for all ptosis surgeries. Particular care must be taken in assessment as not all ptosis surgery require a correction. The amount of ptosis and degree of levator function are the two most important parameters to look for while deciding the ptosis surgery. The other important findings are Bell's phenomena and corneal sensation. The indications for ptosis surgery are as follows. The number one and most practical indication is amblyopia, the degree of amblyopia. And the number two is abnormal head posture. Number three is visual field loss detected in a visual field test. And the last but not the least is a cosmetic purpose. Many surgeries have been done in the past, like fastener servette procedure, levator resection, or aponeurosis reattachment, brow suspension, also called as frontalis sling, and mullerectomy. Among these two, the levator resection and the brow suspension are the most commonly done procedures. Fastener servette surgery includes resection of upper tarsal border along with its attached mulla muscle and conjunctiva. The indication for fastener servette is mild congenital ptosis of 1 to 2 millimeters with good levator function, that is more than 10 millimeters. Horner syndrome, mild involutional ptosis not associated with clear opneurotic defect, mild residual ptosis following a levator resection. The other surgery which is most commonly done is the levator resection. The indications are like mild to moderate congenital ptosis, having a good LPS action more than 6 millimeters, resurgery for undercorrected congenital ptosis, or aponeurotic ptosis where the LPS action is more than 6 to 8 millimeters. The levator resection can be done through an anterior approach and a posterior approach. The anterior approach is called as Everbush surgery, which is depicted in the right upper slide. The posterior approach is a Blaskowitz procedure, which is depicted in the left lower picture. The two most commonly used methods to estimate the amount of levator resection necessary to correct the ptosis are the Burke's rule and the Beard's rule. But I prefer to correct on the table depending upon the preoperative lid position, and that is the most appropriate way, I believe. This is a patient with mild to moderate appendicitis, which is being performed here. A levator resection is being done. The skin incision is put, horizontal skin incision from 10 millimeters from the lid margin. A dissection is carried out to separate the orbicularis from the LPS. And the LPS is separated and it is reattached back to the tarsal plate. So you can see now the sutures being taken from the levator palpebrae superioris aponeurosis, and it is tucked on to the fiber structure, which is the tarsal plate. And the post-operative picture will be something which will be seen like this. So this is immediate next day post-operative picture. You can see the lid, normal lid contour with the sutures in place, little mild lower lid edema and upper lid edema, which will vanish as the day progresses. The next surgery is the bro suspension, also called as frontalis sling. The indications for this surgery are severe congenital ptosis with less than 4 millimeters of LPS action, multiple failed levator surgeries, Marcus Gunn jaw winking phenomena, blepharophimosis, epicanthus inversus syndrome, and acquired ptosis with very poor levator function. You can try bro suspension. Here is a video to show you how the bro suspension or the Fox pentagon approach is performed. 5 major incisions are placed, one on the forehead, the other 2 on the brow, and other 2 on the lid margin. And this is the silicone rod used to pass through these incisions, starting with the forehead incision, then the brow incision, then the lid margin incision. So in a fashion of pentagon, this silicone rod is passed, and the correction is done through the main incision by when the silicone rod is passed through the sleeve. So you can see now the rod is being placed on the brow, then it goes to the forehead. So once it comes out of the forehead, it is made to pass through a sleeve, silicone sleeve, and then this sleeve is buried below the galea aponeurotica so that it should not get exposed. Right, so that is about the bro suspension. As a rule of thumb, the lid will rise by 1 to 2 millimeters if the levator function is more than 7 millimeters, and will drop by 1 or 2 millimeters if the function is less than 7 millimeters. The aim is to achieve the lid level after surgery around 1 to 3 millimeters from the upper limbus, depending upon the levator function. The take-home message from all these procedures is the faucicular servant operation is appropriate only if the levator function is at least 10 millimeters and there is 1 or 2 millimeters of ptosis. In such scenario, it is useful. A levator resection is suitable for the surgery, which is when the levator function is better than 6 or 8 millimeters. A bro suspension is the only procedure which will give a lasting correction if the levator function is less than 4 millimeter, as in case of congenital ptosis. Thank you.
Thank you, Shiva Yogi. This is a nice talk and a very good video demonstration as well. Can I request Dr. Gagan to take over the remaining part of the moderation?
Good evening, everyone. I hope I'm audible.
Yes.
So this session, our chairperson is Dr. Lakshmi Mahesh. She needs no introduction. She's one of the senior most oculoplasty surgeon in Bangalore, and we all have been learning from her over past so many years. And I believe that the case discussion would have tremendous value addition to case discussion by her. Dr. Shiva Yogi is my colleague from Arvind. We trained together, and he has a good oculoplasty practice in Davangere. His wife is a dermatologist who also does cosmetic procedures and surgery, and he is known for his work in the area in Davangere in and around. So I welcome our chairperson and the co-chairperson. And the first case presentation as per schedule is by Dr. Parvati Hari. Dr. Parvati practices in Mysore, and she was with us in Narayan Netralaya before moving on to Mysore. And I hope we'll have an interesting case from her. Dr. Parvati, you can please present your case.
Sure. Recorded version.
Yes.
Committee for giving me. Good evening, everyone. At the outset, I would like to thank the organizing committee for giving me this opportunity. In the last 1 year, we've all seen a lot of fungal infections in the orbit. Here's another rare case of fungal infection. So here's a 6-year-old boy. He presented with a swelling in the superinasal orbit. The swelling was extending over the nasal bridge up to the glabella. It was formed to harden consistency and overlying the bone. There was edema of the upper lip, but the skin overlying the lesion was normal. There was no erythema or other signs of inflammation. The swelling seems to be gradually increasing in size. He gave no history of trauma, fever, or cough. So a CT scan was done. A CT scan showed an ill-defined non-homogeneous lesion that extended from the superinasal orbit into the lacrimal fossa, which seems to obliterate the nasolacrimal duct. A biopsy was advised, but the patient was lost to follow-up as he was reluctant to get a surgery done. He presented 2 months since then with a rapid increase in size of the lesion and persistent watering from the eye. He again had no history of fever, blocked nose, headache, or weight loss. At this point, an MRI was done. The MRI showed ill-defined lesion, again iso-intense on T1 and hyper-intense on T2. It appeared non-homogeneous and the lesion had considerably increased in size compared to the previous scan. With a differential of rhabdomyosarcoma, considering the age group, the location, and MRI features, biopsy was done. The biopsy showed epithelioid granulomas and scattered slender septate fungal hyphae were noted. With the provisional diagnosis of fungal infection, he underwent surgical debridement. This is an extension of the mass that is seen. This is the patient post biopsy, and a curvilinear incision was used, and the mass appeared very firm and firm to hard in consistency intraoperatively. There were no small areas of necrosis that were visible, and also there was a lot of bleeding intraoperatively. Histopathology at this point showed us epithelioid cell granuloma with caseation and cellular infiltrate, inflammatory cellular infiltrate in multinucleate giant cells, and no fungal hyphae was visible at this point. So the provisional diagnosis of tuberculosis was made and AFB staining done and PCR was done for tubercular genome, which came out negative. This is when second look was taken at the biopsy specimen and different sections taken and stained with PAS stain, which reveals slender septate fungal hyphae, which is suggestive of aspergillosis. His systemic evaluation showed elevated SARS-CoV-2 IgG antibody and increased serum IgE and neutrophilia. Rest of the systemic evaluation was normal. He was then started on liposomal amphotericin B. And this is the patient 1 week post starting IV amphotericin. He responded well to the treatment. He also had developed lymphadenopathy around the time of the surgical debulking, and which had resolved with the treatment. Aspergillosis is in immunocompetent patients is rare, and usually the orbital involvement is even isolated orbital involvement is rare, and it is usually secondary to paranasal sinus infections. Clinical presentation is very variable and the diagnosis is very tricky. Most cases get misdiagnosed as other orbital conditions, like most commonly orbital inflammatory disorders, as the imaging is very non-specific. Patient may present with gradual onset proptosis or dystopia or with facial pain. Diagnosis is aided by histopathology, culture, and PCR. Management includes surgical debridement and systemic antifungals like amphotericin B or azoles like voriconazole or itraconazole has been used. To conclude, aspergillus infection is not uncommon among immunocompetent patients. Misdiagnosis is very common due to variable presentations. Histopathology plays a very important role in the accurate diagnosis. Thank you.
Thank you, Parvati, for the case. We discuss now, Gagan, or should we discuss at the end?
We have a discussion after every case as per program,
Okay, yeah.
5 minutes.
Yeah, fine. Now, can you go back on the pre-op scan? Like, what exactly do you think was the cause of this? Was there any subtle foreign body? Because in a small child, to have a fun, it was not exactly contiguous with the communicating with the sinus. In which case, you could have done FES along with an ENT surgeon and debrided, making such a large incision, right? What do you think?
There was no history of trauma as such. So, and when I
children usually will deny trauma, it might have been a tiny, minuscule wooden foreign body or something sitting there.
There was no.
Go back to the scan. Something is amiss in the pre-op And by the way, I would like to introduce Gagan, a dynamic oculoplastic surgeon from NN2 and practicing for the last 11 to 12 years in Narayan Netralaya in Bangalore. He organized a 2013 OPI meeting. It was a very successful meeting in Bangalore, in JP Nagar, and it was appreciated by one and all, and there was a record number of attendance, delegates who attended the OPI meeting then.
Madam, Bangalore is due for the next meeting as well. It's been many years
Definitely.
now.
It's so
So I
many
think
of
so
us
everyone is
here.
here. All of us, I think so, can put a bid again now.
Yes, very
maybe
true.
Whenever
That's a
time
very
comes.
good valid point, and I appreciate you for that. We should do it.
I'm here, sir. So
initially,
there was no foreign body. There were no signs of an injury. Like he had presented to me about a month.
Correct. No, I'm not doubting. Without any contiguous spread from the sinus, to just sit there and walled off, or
And
was it some abscess?
so he was lost to follow.
Lacrimal abscess?
There was no history of watering in the beginning. When he came back about 2 months after I initially saw him, that's when the watering had started.
So the lacrimal gland was, your sac was completely debrided, is it?
Post-surgery, yes, ma'am, completely debrided.
So you have done something like a DCT in addition?
Yes, yes.
Okay.
So I had worked along with the ENT surgeon. There was no involvement of the sinuses. They had done an endoscopy. So sinuses were all normal.
Yeah, that's why even on the pre-op scan, it looks pretty clear. Okay, thank you.
So we probably really don't know what started off this infection. Couple of things interesting. You have COVID antibody level raised. So probably patient did.
It could be why the
Yes.
lesion suddenly started increasing after a certain
Could be.
time.
And one thing which is important is if we see with all our investigation, biopsy still is something which is really, important. So our diagnosis in this case comes once you took the biopsy.
Yes.
So many a times, we try to investigate more and we push biopsy in the end, considering, it's invasive or, we'll try to, but the biopsy and early biopsy, especially when indicated, is really important. You lost the patient and, it was rhabdo would be definitely a much higher differential than, a fungal that would go down the line. So considering rhabdo and you took an early biopsy.
Yes.
And also one other point is that if it's an unusual case, I personally believe that, giving a heads up to pathologists sometimes saves us time. So in your case also, the first, report of biopsy did not show fungus, and then you had to go back and have a second look.
So actually what happened was the initial biopsy was done in Bangalore, Dr. Roshmi had done. So there the reporting, it said fungal elements, but then patient came back to Mysore, and when we did the excision, so the pathologist was seeing it for the first time. They were not convinced of the diagnosis because it didn't look like a fungal infection. So that's why the initial confusion.
Yeah. Keep also the gene expert test in your armamentarium, because you had subjected the smear for AFB also. Many a time it may not show up between chronic and the chronicity increases, some amount of fibrosis sets in. So take that fresh sample of tissue, and here you had abundant lot of tissue. Send it for gene expert. Generally, you get the result within 48 hours. I'm sure a lot of good labs are doing, and they could even outsource it for you.
So that is when we actually thought, okay, it is definitely not tuberculosis and something else. So.
And the post-op result looks good, because sometimes in fungus, we know how much debridement we have to do, and post-op is, really not what you would like, aesthetically pleasing. So,
unfortunately,
whatever the
as watering, which is a big concern now. So like
a bit of your leftover Botox might help the child.
He's only 6 years old, so
Botox you can give her.
No. I think she should go for an endoscopic DCR a little later with intubation, though the results may not be that great. Because there's no sac here. Wait, now just make sure that pathology doesn't come back.
Yes.
Is he still on some posaconazole or something, or only?
He was on amphotericin B. So he would be switched to voriconazole after that. That will
How
go on
long is he on AMFO now?
about 3 weeks now.
Watch out for all his renal parameters, liver parameters. Keep the pediatrician in loop.
The
Okay?
pediatrician himself is like managing
Okay.
the case, right?
Okay.
Dr. Shiva Yogi, would you like to add something?
Yeah, Gagan, thanks so much for the caring words you always give to me. And no doubt, Dr. Lakshmi Mahesh has told about you is exactly right. The way I'm watching you since 2006 or 8 something. Great work. Keep going.
Thanks, Shiva.
Regarding this case, was there any history of swelling in the medial canthus?
Yeah, there was a
because
supranasal quadrant, there was swelling initially.
because one case, I think one case of mine, which I can remember, it was a burst dermoid, where the local ophthalmologist had managed it as a ulcer for long-standing ulcer.
That's a good point.
Yeah, and because it is at the sutural junction,
Yes.
so then I have to take a CT scan and discuss with the radiologist of my probabilities. Then when we expose, we could see the sac, I mean, the opened sac. So I think this could be an infected, fungal infected burst dermoid, something like that, in a young age, where the diagnosis is not uncertain. Fungal infection at that age, I mean, non-immunosuppressed patient, quite unlikely. It could be a contaminant from outside, probably. I think so. I don't know.
I would also tend to agree with you on that.
Is
Yeah.
it possible that he got a dacryocystitis first and that extended?
That's what history gives us the clue. History is very, very important. Dacryocystitis, there will be a history of visiting pediatrician, ophthalmologist, massage, all those things. Then watering, discharge. So that will be a typical history you will have. Or if it is a dermoid, there will be a lump, a small lump in the superomedial quadrant. So the history plays a vital
important thing
role.
is what Shivayogi is saying is the lesion has extended above the medial canthus. Even in a pediatric, it's usually very unlikely that the abscess will go above, but sometimes we do get. But here it is nice and confined. So I think dermoid is a very, very strong possibility, Parvati.
Okay.
A ruptured dermoid, infected dermoid, or somebody tried a surgery where it was an incomplete excision, again going for, it goes for inflammation, then again superadded infection, something like that we can think of. Unlikely it is a malignancy, as Gagan has pointed out, because the orbital margin, everything is normal. I mean, unlikely it is a malignancy, rhabdo, something like that, no. But it is an inflammatory or infective lesion, something we should look in for.
And if you have all the CT cuts, especially sometimes they don't take out all the prints because of cost cutting. In many places they give CD. Just run the CD again and see if there was any bone scalloping.
I discussed with the radiologist, ma'am. So there was no bone involvement at all. Like even the CT, even MRI, from what they could make out, it was not there, which is again goes against the fungal infection picture.
Should we move on to next case?
Yeah, sure.
Thank you.
Okay. Thank you, Parvati, for a very interesting case. These cases always, make us think, and parents hiding history is always a problem. So, parents and patients, sometimes they don't reveal history, and, we really have to spend time on that. Next case is by Dr. Shefali Shahar. I have not met her personally, but what I know is she practices with Dr. Fairuz, and she's quite active in academics. I've seen plenty of her presentations and posters in other meetings. Over to you, Dr. Shefali, for your case presentation.
A very good evening, everyone. A very good evening, everyone. At the outset, I would like to thank Karnataka Ophthalmological Society and Scientific Committee for this wonderful opportunity. I'll quickly share my screen here. So today, I would like to take you all through some roads that may seem difficult or daunting, but trust me, they end in beautiful destinations. I would like to acknowledge Dr. Fairuz for her guidance and Horace and Hope for the patient archives. Eyes. Our eyes are the very precious organ of sight, but they also play a very major role in facial aesthetics. Imagine the loss of such a precious organ. This can either be in acquired cases, scenarios listed here, or as congenital anomaly. Loss of such a precious organ can not only cause visual handicap, but it can be totally psychologically devastating for the patients. And hence, it requires appropriate cosmetic rehabilitation. An ideal socket requires appropriate size central implant, adequate surface and volume. But challenging scenarios can present many times that result in different grades of contracted socket, classified according to the severity of surface and volume loss. Such conditions require patient perseverance for best results. Through this talk, I would like to take you through journeys of few patients highlighting their management options and results. Starting off with few congenital cases, this baby boy presented to us at 3 months of age after full-term normal delivery. No significant prenatal history was noted, although he was found to be CMV positive after birth. What we had here was congenital microphthalmia, and as you can see in such cases, there is a decrease in ocular size as compared to the contralateral side, and there is bony orbital hypoplasia. So some form of stimulation is required for the orbital growth. As step one, we went ahead for surface expansion. We went ahead with graduated serial customized ocular prosthesis for this baby, starting at 3 months of his age. And as you can see, the results were very satisfactory. As step two, he underwent enucleation with PMMA implant. And as step three, customized ocular prosthesis was provided for him at 3 years of age. And as you can see, he achieved excellent cosmesis. In fact, in congenital cases, the early we intervene is better. In fact, we have had cases who have presented us as a neonate, and we have started intervention in the neonatal age, as in this case. But what happens if no intervention is done, like in this 19-year-old girl who came with a left eye congenital defect? The bony socket actually contracts as is evident and measured from the CT scan here. My next case is this gentleman with anophthalmia and microblephron presented at 24 years of age. Such cases of severe volume loss, dermis fat graft, which is an autograft, is an excellent choice for volume replacement. So we went ahead as step one with DFG and fornix formation suture for him. As step two, customized ocular prosthesis was fitted for this patient, leading to excellent cosmesis. And many times, nature works its own way to help, like in this 8-year-old with microphthalmia of left eye. Closer look of the socket reveals microphthalmic eye and a bluish large cystic lesion next to the eye. CT scan confirmed the presence of congenital cystic eyeball, and as you can see, together the space occupied with this anomaly resulted in adequate bony growth in this case. He recently underwent enucleation with the 20-size PMMA orbital implant, and he awaits his COP in the coming week. My last case for the day is this 26-year-old gentleman who had right eye retinoblastoma detected in 1990 and underwent enucleation followed by external beam radiotherapy. This led to grade 4 contraction with surface and volume loss. Radiated sockets are definitely rare but challenging as there is vascularity gets compromised. Step one for our patient here was mucous membrane graft for the surface reconstruction with fornix formation sutures. The graft was harvested from the lower lip. Step two, the options on the table were dermis fat graft or customized ocular prosthesis, but DFG can actually be challenging in such radiated sockets. So we went ahead with customized ocular prosthesis for him, and he achieved excellent cosmesis. He's happy and but has been advised for regular follow-up. So I would like to stress that as a team of oculoplasty surgeon and ocularists, we should not give up on such cases. The road might be long and difficult, but gives a satisfying outcome. Near normal cosmesis is possible, which can change the quality of life of these patients immensely. And also in congenital cases, the earlier you intervene, the better. Thank you so much for your patient listening, and I hope everyone has a good evening. Thank you.
Thank you, Dr. Shefali, for an excellent presentation, and the spectrum of cases with the outcome was really pleasing to eye. May I request Dr. Shiva Yogi to start discussion for this patient?
Okay. Yeah, Shefali, I am Dr. Shiva Yogi from Davangere. The road is not, yeah, good evening. The road is not so good as you have shown in cases like this, where cases like anophthalmic socket, congenital anophthalmos, and cases where the radiation exposed orbit. I think I have few cases in my experience where most of the cases the outcome is not that good. You're not happy as you are happy with enucleation implant or this evisceration implant. We have tried dermis fat graft. I have not tried any mucous membrane graft, but I feel see it's a challenge. You see, you have a 5-year or 4-year kid where there is a contraction, and it's difficult to do a dermis fat graft in those patients. And a patient coming at 10 years or 15 years, you have a severe contraction. I don't know. Dr. Lakshmi Mahesh, madam, would have a good exposure in this. I think I might have done around 15 or 20, very less such cases, and most of the cases will come with again this rejection of the graft or expulsion of the prosthesis. It's a unsolved misery for my practice, as far as my practice is concerned. Some patients are doing very good. Some patients have done repeat surgeries, 2, 3, 4 times I have done surgery. Some patients are not happy with 3rd surgery also. I don't know.
So Shiva Yogi, I think to cut a long story short, socket reconstruction is a big saga. See, when you have, first you have to think of, just like in lid reconstruction, you have cover, support and lining. In socket reconstruction, you should think of lining and you should think of volume. So if it is severely contracted, they are desperate to have a shell. So think of lining. What kind of a lining you can give? The best is mucous membrane. I've even given mucous membrane from gray line to gray line. Okay, and volume. If volume is the implant. Now, I think Kasturi tries to do both the surgeries in the same sitting. You could do, but I like to keep dermis fat graft as one of the last options. First, your own eye, even if it is shrunken, preserve the nature. So in a case of even microophthalmos with cyst, remove the cyst if you wish to, but don't remove that small eye. That small eye will act as a stimulus for the growth of the orbit. So please keep that icicle eye. Anything, if the eye is there, retain that as much as possible. Give the conformer. Start with tiny conformers. We have Archana Murthy here in Bangalore. Fairuz is associated with them. Just start with tiny conformers and serially expand. I've given conformers as early as 4 days. So you can fashion beautiful, tiny acrylic. SMR also markets them. Just give those conformers and start the serial expansion. 1 month you change it, 3 months you change it. Just try to give a shell there. If the shell is there, the parents are so happy. So first, when you see, try to retain the eyeball as much as possible. If you have to remove it, okay, put an acrylic or silicone implant. Then if it is a child, later on, you replace it with a integrated implant. And as much as possible, see that there is a good lining there with the phonics. If necessary, take phonics forming sutures, keep it for 4 to 6 weeks there, and do your flushings in the lateral or the medial end. Let the pillars, tassoraphy on bolsters or whichever kind of bolster, preferably Sofratule or Bactigras bolsters, paraffin bolsters. Do the flushing through that. Conformer is there, and take it out after 4 to 6 weeks. It will look a little edematous, but it will settle down. Then you give the shell. Then you see what next you have to do. If there are fractures, if there are bone augmentations, tries to see if you can do some sulcus formation. So go step by step. So just see, when the patient comes to you first, what is that it is needed? Do I need volume? Do I need lining? Do I need phonics formation? Invariably, it will be lining because they are desperate to have a shell.
So Dr. Shefali, if I sum up.
Sir, yeah, for sure.
Yeah, I think
so the road is definitely long for us also. I think I just kind of like contracted it for a 5 minutes presentation. Radiated socket, I have seen one other boy, Dr. Fairuz had operated him with DFG. He's thankfully, fortunately, till now doing well. But yeah, even for my last case, he missed his follow-up. We were so angry with him that he should be
And
coming
see,
for
the
follow-up
DFG,
so
when
that
you
he
put in,
doesn't.
the phonics should be found well. Even if one flat
Yeah.
globule gets infected, just like acrylic implant they bring back in their hand when it pops out, the fat will start coming out bit by bit by bit. It will start, it won't necrose fully and come out. It's agony. Every time they'll come out with one fat globule there. So to try to keep that DFG as one of the last options, okay? But if you're putting DFG, it's no harm, but make sure you have enough lining to put in the conformer in the same sitting or a few
Correct.
days down the line.
That's what for the last case, ma'am, DFG was an option, but then we went ahead with the COP. Like the COP was customized and it's like so
Okay.
thick. We did not go ahead with the DFG for him. And till now he's doing well and we are like very strict with him for the follow-ups and everything. So hopefully
That's good.
he'll be good.
Yeah, I was actually about to ask you about that big prosthesis. Is it a hollow prosthesis? Because, you know, if it's not hollow, retaining that might be a problem because of
It's
weight.
not,
But fourth
yeah,
case,
the weight is not,
will it be
no, the
possible
weight
for
is
you to
not heavy,
just,
so it's not like it doesn't.
yeah. If you don't mind, can you pull out that photograph? It's, I think, so the fourth case, the one which you showed the prosthesis. That's what I'm talking about. It was
The
just
last one. So,
Last
so
one.
our Ocularis does make the hollow prosthesis, but yeah, this one.
You could even use a similiferon ring.
There was one photograph which showed the prosthesis alone in one slide.
Yeah. This one.
No. Yeah, this one. See, this one, you know, is going to be heavy. Yeah, this is pretty
actually
thick.
is not a hollow prosthesis, but it doesn't.
Yeah.
Yeah.
So what will happen with this
wasn't
is
leading to the lid sagging or.
Yeah. So my thought on this is, and what I have seen is, this one will fit fine now because the socket is already contracted. So the structures are tight. It is going to be a tight fit. But later on, definitely the lower lid will sag with this. Or, you know, the processes will start popping out. So this one, if we have to dispense this big, either it has to be hollow or we can actually go in for shells. So there will be some space in the back. It's okay. This is definitely, if you weigh this prosthesis, it's going to be heavy. By heavy, I mean to say it will be more
So
than
the socket
2.
of the patient actually, right now it's like fitting well for the patient. And
later on
it needs modification because our Ocularis does make the hollow prosthesis, which actually floats and it's like quite
so this one
right now his lid and all is not sagging. It provides good cosmesis for him.
Yeah. So just to add upon to the case, an ideal socket volume, what we are looking at, the prosthesis is around 2 to 2.5 ml. And the central thickness we are looking at around 5 to 6 millimeters. So considering that to be an ideal prosthesis, this one definitely is heavy and this one definitely is thicker, but it is fitting the patient is happy and we have to customize. So nothing wrong with it. That's the only observation I have, that maybe it might be big for the patient and anyways you can adjust it later on. That's all.
Correct.
And other thing I would like to ask you, the first patient which you showed the child, you did the enucleation, the first patient. You mentioned you could fit in a 20 millimeter prosthesis after enucleation.
20.
Yeah.
Yes.
So
around 3 years of age, he underwent enucleation.
Yeah. So that is a little, it caught my eye because if it was a microophthalmos and the kind of picture we have, even if we enucleate, putting in 20 sometimes is tough because there is always a mild, you know, there'll be some amount of bony contraction there. So it varies on case to case.
We try to put in definitely 20. We try in first. And in this patient, we could actually fit in the 20 number implant.
Yeah. So that was a little.
Definitely 18, but we try, even in children, we try to like thrust in 20 number implant for sure.
But many a times in this microophthalmos, fitting in 20 is a challenge. So that is what I was trying to say, that even in that patient took 20. But mostly fitting in 20 is a challenge in these patients. You know, sometimes we end up putting in a smaller prosthesis, a smaller implant rather.
This patient actually has been like really regular with the follow-ups and the surface has like really expanded nicely for him. He started at 3 months and then at 3 years he underwent this surgery. And in fact, this October only he got his COP, the last picture that I showed. And definitely the parents were like really happy with the cosmesis that he achieved.
Sure. Thank you, Dr. Shefali. With permission of chair, we'll move on to next case presentation. Lakshmi Madam, should we go to next presentation?
Yes, please. Yes, please.
The next presentation is by Dr. Kavita. I'm sorry, the title of
Doctor, she's
presentation.
not there.
Okay.
Next is Dr. Sushma.
Yeah. So Dr. Sushma is my colleague from NN. She is in NN1, works with Dr. Roshni there. And, she's also doing lots of work in. Hello. Yeah. Dr. Sushma, can you please present your case?
Karnataka Ophthalmic Society, Dr. L.M. Kumaran and the entire scientific committee for the kind opportunity. I'm going to share my screen. So today I'm going to present an unusual presentation of conjunctival myxoma. No financial disclosures. Consent has been taken for all the clinical photographs used. So myxomas are benign connective tissue tumors of mesenchymal origin. They occur in the ocular adnexa, cornea, and conjunctiva in the eye. Conjunctival myxomas are a rare occurrence. They can masquerade as more sinister lesions such as conjunctival lymphoma, lymphangioma, ocular surface squamous neoplasia, or amelanotic melanoma. So the present case is of a 50-year-old male who presented with complaints of fullness of left upper eyelid nasally of 1 month duration, which was progressively increasing in size and was painless. No known comorbidities. So this was the patient at presentation. His best corrected visual acuity was 20/20 N6. The anterior segment of the right eye was within normal limits. On the left eye, there was a medial droop of the upper eyelid, and on manually lifting the upper eyelid, there was a 20 cross 15 millimeter pinkish white firm mass superior-medially over the fornix, which was non-tender and non-reducible. The extraocular movements were within normal limits. Rest of the anterior segment and fundus examination were unremarkable. So the patient underwent excisional biopsy with histopathological examination. The histopathological examination revealed stroma with myxoid appearance with interspersed benign spindle cells, thereby clinching the diagnosis of conjunctival myxoma. This was a patient at 1 month follow-up. The lower picture is of the post-op pictures. The medial droop is gone. Both the eyes are more symmetrical and the lesion is not to be seen. So there was no recurrence at 12-month follow-up period. So myxomas are benign tumors which are rare and are discovered in sinuses, pharynx, heart, breast, intestines, genitourinary tract, skin, muscles, and bones. The incidence rate of conjunctival myxoma is as low as 0.001% to 0.1%, thereby making them an extremely rare ocular neoplasia of primitive mesenchymal origin. It was first described by Magaluf in 1913, followed by a limited number of case reports subsequently. It is usually found in older patients with a mean age of presentation being 47.6%, which is very much similar to our present case. There is no gender predilection. They usually present as slow-growing, painless, well-circumscribed, yellow-pink cyst-like masses, thereby making conjunctival cyst the most likely diagnosis. However, the differential diagnosis includes more sinister lesions such as amelanotic nevus, lymphangioma, myxoid neurofibroma, myxoid liposarcoma, and amelanotic melanoma. However, clinically well-circumscribed borders, absence of recurrence, and histological absence of pigmentation, sparse vascular structures, and cellular morphology differentiates conjunctival myxomas from these lesions. They're usually found in the bulbar conjunctiva, followed by limbal, fornix, and palpebral areas, and they have a predilection for temporal conjunctiva more than the nasal conjunctiva. So they're treated by complete excision, as in the present case. Recurrences are very, very rare. And the characteristic HPE findings, which are diagnostic, usually include sparsely scattered stellate and spindle-shaped cells in a mucinous matrix with delicate reticulin fibrils, minimal blood vessels, and mature collagen fibers. And the systemic associations include Carney's complex and Zollinger-Ellison syndrome. Carney's complex usually includes myxomas, spotty mucocutaneous pigmentation, endocrinological overactivity, and psammomatous melanotic schwannomas. Any two of the following features should be required for the diagnosis. And Carney described that in patients in whom the ocular myxomas precede the systemic features, those patients are at higher risk of vascular embolic events. Thereby, early identification of ocular myxomas and subsequent screening and monitoring for cardiac myxoma is recommended. A patient underwent cardiac screening and it was unremarkable. The present concept is that the mutation of PRKAR1A gene with abnormal subsequent CALP-dependent protein kinase A is associated with more aggressive and systemic myxoma lesions. However, further research is needed in this regard. So in conclusion, these are benign tumors. However, they can mimic more sinister lesions. The importance of excisional biopsy lies in the fact that it is curative and also that the characteristic HPE findings, which are diagnostic, help in the diagnosis. And the association with systemic syndromes can lead to the detection of previously undiagnosed cardiac myxomas, which, if left undetected, may result in vascular embolic events. Thus, a careful ophthalmic examination and the correct diagnosis based on HPE findings can help in the diagnosis of these rare conjunctival neoplasia. Thank you. Thank you all for the kind attention.
Thank you very much. Sorry, please go ahead.
I was coming to you, madam. I was saying thank you, Dr. Sushma, for your presentation. And we now move on to madam to start the discussion.
Oh, it's nice to see all these youngsters. Sushma, Ajay, and all, I'm meeting them for the first time. Nice. Sushma, can you just go back on the histopathology slide, please?
Yes, ma'am, just one.
Because a differential diagnosis is the important thing. Is there any kind of a trauma where it brought in some muscle, superior oblique muscle, and some fibers also there? There are fat cells also, right? You can see adipose tissue is also there in the second slide below. What was the description? Just show that description of the histopathology by the pathologist, please. Stroma with myxoid interspace benign spindle cells. Okay, that's it. Any special stain was done? Immunohistochemistry. I'm not sure whether you can hear me. I can't hear anyone.
You're audible, madam. I think so. Sushma has lost connection or there is some issue at her end.
Sorry about that.
I'm here.
Now we're here.
So I discussed.
Any special stain was done for this?
Ma'am, actually PAS was done, but it was negative, and then the pathologist was pretty much sure about her diagnosis, and she told
Now
us.
you see the second slide there, lot of fat cells are there.
Yes, ma'am. Like I went in a little more aggressive, and some of the orbital fat was also spent.
Did you get a scan done? Because even for a case of conjunctival fat prolapse, which many times drastically patients come, generally they are obese patients with sleep apnea, with a lot of snoring, and they rub their eyes and they get this fat prolapse. It's usually there in the lateral aspect, because we have to be very careful because the palpable lacrimal gland is in close proximity. Medially, we are worried about the trochlea, that is the superior oblique fibers. So do you think there was some trauma, or was there any small mucocele of the frontoethmoidal sinus there, which would have just, along with that, brought down the muscle and the fat? All this we have to think of, You have to give the leads for the pathologist. Please don't believe the pathologist or the radiologist 100%. At this stage of your careers, you have to sit with the slides. You have to sit with the scans. Go through all of them, take their help and guidance, but you have to do that. So somewhere I think I won't take this 100%. I'm not doubting your diagnosis. I'm not doubting the pathology, but keep all these DDs in mind. You youngsters, you should ask why. Should not blindly believe what they say, and yeah, this is one sole case, because the incidence is so low, less than 0.001, like hyperthyroid values you are telling. So I don't know really. Yeah. Because the second slide is showing a lot of fat cells. You go back and ask your pathologist.
Sure, ma'am. The immunohistochemistry was done, which was positive only for Vimentin, ma'am.
Vimentin, it will show many things.
Yes, ma'am. It's not very specific, but it was negative for smooth muscle actin and Soxton and the glut1, ma'am. So, which is
ask him whether he sneezed or coughed forcefully, whether he had a mucocele. When there is something unusual, no harm in getting a scan done, a
Sure, ma'am.
screening scan done. Okay. Yeah.
Sure, ma'am. Thank you.
Very good.
Sure. So, Dr. Sushma, just one question, and this I'm asking on behalf of audience because there are no audience question. If we go to the clinical presentation, which is few slides before that, where you have shown the lesion.
Yes, sir.
Actually, I should congratulate Sushma for the meticulous presentation. All of you so far,
Yeah.
Shefali, very nicely, everything in steps it's been presented.
So
That's
my
nice.
question to you, Sushma, is that I am not an oculoplasty surgeon, and if I see this patient, what would be my first diagnosis or suspicion here? Myxoma definitely might not be the first one. So
Correct.
once
That's the
you saw
point.
this patient in OPD, what is our starting point? What is here, and how do we plan for it, and what is our plan for management here? So
That's
what would
the
be the
point.
first?
In fact, this case was first seen by a postgraduate on a Sunday duty. So I would consider her as a general ophthalmologist. So her primary diagnosis was orbital fat prolapse. And then she was thinking of lymphoma. And as madam pointed out, yes, small frontoethmoidal mucoceles, although very unusual. And maybe a general ophthalmologist could go ahead with orbital imaging, a CT scan of the orbit that might, rule out few of the more definitive diagnosis.
So this, when you see, is not a mucocele. Something
ma'am.
from
This-
there is pushing the fat and the muscle there. Okay.
Yes.
So if you notice, there is some subtle fullness. I don't know, but definitely in such unusual cases, a scan is needed. Okay. Yeah.
Sure.
Thank you, Dr. Sushma. Lakshmi Madam, we have only one more case presentation, and our session is available to us till 9. So since there are no audience question, everything, but we do have all our colleagues still, in the participant list. So if you, after the next case, I think so, the floor can be made open to everyone to have their discussion or any addition to what we have discussed after this
Yes.
last presentation.
And even those who
So-
are presented, if they want to say something more, they could please.
Yes. And the last presentation for this session will be by Dr. Bindu Malini. So after she finishes her case, the floor will be open for everyone to interact. So I would request anyone who has anything, please share your thoughts on all the cases.
Good evening all. I'm Dr. Bindu Malini, Assistant Professor at JSS Medical College. I would like to thank the KOS office bearers and the conference organizers for giving me this opportunity. I would like to share an interesting case which I recently came across my practice. So this is about the orbital secondaries. As we all know that orbital secondaries or any malignancies need a thorough evaluation. So I'm presenting the case report of a 31-year-old male patient who came with complaints of protrusion of the right eye progressing over 1 month with blurring of vision and diplopia since 2 weeks. On examination, his left eye was completely normal, whereas in the right eye, the vision was 624 with no further improvement, and anterior segment evaluations showed ill-sustained pupil. On examination of orbit, there was moderate proptosis with eyeball pushed slightly downwards, and a soft to firm mass was palpable in the superotemporal quadrant, ill-defined, with mild tenderness and minimal resistance to retropulsion. There was no hyposthesia of the surrounding skin and no regional lymphadenopathy. So these pictures show the extraocular, complete restriction of extraocular movements in the right eye, and the profile view of the right eye compared to the left, and the worm's eye view of the right proptosis. On imaging, the patient underwent MRI, and we can see a lobulated mass with blood fluid levels and hyperintense on T1 weighted images and flare images, causing compression effect over the superior and lateral rectus muscles, and had high intense post-contrast enhancement. So we planned for excision biopsy of this tumor via anterior orbitotomy under general anesthesia, and the intraoperative findings were as follows, where we saw a soft tissue mass which was firmly adherent to the bony orbit with erosions of the bone. The biopsy report came as malignant epithelial tumor, but they could not place it under a specific subvariety for the lacrimal gland tumor. So we sent the same sample to a different center, and they told that this looks like adenocarcinoma, but more like a metastatic variety rather than a primary of the lacrimal gland, because it showed more desmoplastic reaction with bony infiltration and less tissue necrosis, which is very classic in lacrimal gland tumors. So patient underwent CT, PET, and lytic lesions were detected in the posterior iliac bone and also in the apical region of the left lung. This tissue was subjected to immunohistocytochemistry, and all the markers which were done in relation to the lung metastasis were turned out to be negative, and the molecular markers were also negative. So this was termed as a wild type of lung adenocarcinoma. So the final diagnosis being the primary lung adenocarcinoma with metastasis to the right orbit and posterior iliac bone. Now the patient is undergoing chemotherapy. A total of 6 cycles have been planned with injection pemetrexate 800 milligrams, carboplatin 600 milligrams, zoledronic acid 4 milligrams, and he has completed second cycle of chemotherapy, and this shows the resolution of proptosis. He is not undergoing EBRT because there is no localized pain near the orbit region. And as we all know, lacrimal gland can get metastasis from breast and lung primaries, also renal and prostate primaries. The presentation was very similar to the presentation which I've shown in this case presentation. So the take-home message is, whenever in dilemma, always send the biopsy samples to do different places, especially if it is malignant. And this will give you a more insightful information as to what the lesion can be. Thank you one and all for your patient listening, and thank you KOs again.
Madam, if you don't mind, you can leave your presentation on. You can share it again. Dr. Shiva, would you like to start discussion on this case, please?
I think you should go back to the first slide. Mindu, please
Dr.
go back to
Ravijan?
Yes, ma'am. I'm going back to the first slide. Is the screen visible?
Yeah, it's visible.
Please
Yes.
make it full screen, that is
Ma'am, I can expand it only to this much.
okay, fine.
It's okay.
So it's only
Shiva.
31 years old,
Yes, yes,
right?
ma'am.
So we have to see whether he was immunocompromised. Did you do a HIV and all those
Yes,
tests?
ma'am. Yes.
Workup?
We do it routinely for any case which we take up for surgery.
History of smoking?
No, ma'am. No history of smoking.
And the PET scan, okay, going scroll up. Shivayogi, you have anything to ask? Go down a little bit, sorry. Go
For the-
down a little bit. No. It's looking like thyroid eye disease, no?
Yes, madam. There is a retraction in
Gross
the lid retraction is quite the left eye also. If we
even in the
see,
left eye also. Of course, there is
Yeah.
proptosis here.
so-
But we could detect this mass and
Wait. Go back to the imaging.
yes.
Imaging. It's okay this time. I'm not trying to be pointing fingers, but when you bring in as an oculoplasty surgeon, you should not just bring random like this, It's a strain. You should take a little bit close-up photos on the salient things,
Yes.
mark it and bring it across. Then it will have more impact
Okay.
because you're not able to expand it also here.
I
So
can
it's
do that.
brilliantly vascular. So what if I say this lesion first metastasized to lateral rectus and there was spillover involvement of the lacrimal gland? How would you argue for what
yes,
I
ma'am.
have put up?
Actually, when we send this sample to the pathologist again for the second opinion, they told that the tissue doesn't show any lacrimal gland involvement. It doesn't have any lacrimal gland tissue at all in the mass. So
Correct.
that is when they told that this can be a metastatic lesion.
See,
In fact,
lacrimal
if
gland.
in fact, if we go to the excised tissue, which is the next slide,
Yes, sir.
it looks like a cystic thing which got opened. Like it looks cystic because the inside is all epithelial line kind of a structure. So
Yes.
that was my question to you, that if it's a metastasis from adenocarcinoma, why it is cystic?
I know, sir.
Can be because it can be very vascular. Again, when you're
Yeah.
showing such a slide, you should have a totally white background or a total green background or your
Okay.
plastic sheet. And
Okay.
this looks very rustic. It looks like you've gone to a expedition and from there.
I'll do it next time.
Yeah.
Actually,
so, I'm just telling you all this. Don't take it in the negative.
No,
But
ma'am.
it makes a present.
Actually,
And then the final crux of the presentation should not have been lacrimal gland. We thought it was lacrimal gland, but probably it could have gone from the lateral rectus to the gland. That if you had added that one line, then you won't point
there
fingers.
were no muscle fibers involvement in this mass, which I excised, ma'am, and the lateral rectus was completely free from the tumor area. Only thing is that this was fully filled with fluid, and when I was trying to remove it from the periosteum, I mean from the bone attachment, it completely opened up. So there was a lot of fluid spillage.
Usually it's very vascular. The secondaries
Yes,
from lung and all are very vascular. You'll almost mistake it for a vascular lesion. But then, there's such a short history. Now go back to the PET scan.
Yes.
Where is a lesion? It's mediastinal lesion, is it? Or it's a conglomeration of all
the apical portion of the lung, left lung.
It doesn't look like the apical portion of the lung. The lesion in the center is the mediastinum. It's not the apical portion of the lung. When it's apical portion, you'll see only very little. This is cross section.
This was the report given from
Then this report also should not be like this verbatim. You should make a small history and put it there. And now scroll to the right where the PET scan is. Bladder will always fill up.
Yes.
FDG, whatever they call it, it will always fill up. What is that in the pelvis, or is it the kidney? Maybe
the iliac region also had metastasis. The posterior iliac bone.
So that's the posterior iliac what we see.
But then the lung per se is not showing a very frank lesion at all. There's nothing in the lung.
Yes, ma'am. Actually, the oncologist is planning for the lung biopsy also, the lung node biopsy also. I think they have done it.
So still the patient has not started treatment.
He is already on treatment.
Chemotherapy has been started, madam. She mentioned.
Based on what then?
Based on diagnosis of adenocarcinoma. So the chemotherapy regimen for adenocarcinoma.
They have done the immunohistocytochemistry also for this case. And it was pointing more towards a lung primary rather than lacrimal primary.
So it's a small cell carcinoma from the lung. Where is the biopsy report? Or the slides of the biopsy?
The biopsy report, ma'am.
Report, is it?
This is the first report which I got it from my college itself. And this is the second report. The second report I sent it to Shankar Netralaya. So they gave me this report.
Nobody has the patience to read. You should do homework on it and send only the 2-3 points.
It was quite a lengthy report. I have selected only few sentences from it.
Should not even do that. You should just show the slide at least. You should describe it, okay? Should not think it's a work of the patho. See, here there is a lot of inflammatory cells I can see.
Ma'am, this is the glandular pattern and very minimal tissue necrosis, which they told that is not very typical of a lacrimal gland primary.
These are mostly looking like lymphocytes. I don't know whether there is any lung, small cell carcinoma, lung lesions. Because usually the small cell carcinoma from the lung only metastasis very rapidly to the orbit in such a young patient. And the primary may be a very subtle, tiny primary in the lung. So just as what your PET has shown. Somehow I think you'll have to, sorry to say this, Bindu, thanks for bringing out such an important case because there are some loopholes, but please go back and work up the patient again.
Okay.
And you be in the loop, don't leave it to the others.
No,
you
ma'am.
You have done the orbital part of the biopsy and you are a very vital, and it has come with the orbital problem first. So you are vital in the management of this case.
Dr. Bindu, thank you for this presentation. With your
Thank
take-home message, which you had mentioned about histopathology, I'm
Yes,
just sharing what I do and what I feel. So
Okay.
many a time, if we get a primary histopathology report for an, something unusual, like we had a myxoma case and all, if that report doesn't explain what we see,
Yes.
it's a wild goose chase. We actually go up wasting time, effort, doing more things, right? So the only lesson what I have learned is that if you are well connected to a pathologist, yours is a medical college, there'll be multiple pathologists.
Yes,
So
sir.
first choice, if there is an oncopathologist, I would prefer that all these samples go to oncopathologist. And
Yes.
I do tell them, please call me before you report, or please call me as soon as you start reporting.
Okay.
Because the same thing happens here. Once the report is generated, then, to get a revised report, sometimes they keep on trying to say that our first report was right. And, let's add a doubt here and add a doubt there. So rather than having a report and given to a patient and then trying to revise, any patient where things are not clear to me, like I operate and I found out, yeah, there's something suspicious, like you found. So my thing would be to chase the pathology and say, before reporting, let's discuss this case.
Okay.
That quite, saves us time. And in fact, if they are not sure, we have a discussion of taking a second opinion in the department itself. They can put it up in their departmental discussion before the report. And, those things can be done. So that actually saves quite a bit of time after we get the report. And in these cases, I would tell patient that, whatever turnaround time you tell to patient, let's say you say our report will be ready for 5. If it's a suspicious report, I would tell them it is going to take time. It will going to take 7-10 days. So patient also are waiting for 10 days. By the time your biopsy site is healing, all the things are okay. But I would personally be chasing the pathologist before the first report is given. And I would try to have oncopathologist report this, but if you don't have a choice, I would go with the pathologist who is ready to discuss with me.
Yes.
Who doesn't mind us doing
the second time when I sent it to Shankar Netralaya, I personally spoke to the pathologist, sir. So after that only, I sent the patient for rest of the investigations.
Yeah, no, I was sharing my personal experience, not commenting on your case.
Yes,
that
sir.
Probably, taking pathologists into loop before that report is printed. Many a times, saves us lots of things. Because if they are in doubt, we tell them, put it in your departmental meeting, put it in your department difficult cases. One of their postgrads will present. One of their postgrads may actually go and work up in more detail. In a teaching college, postgraduates are always there and they would like to work on this thing. So a pathology postgrad might take in some effort. So this is just what I would do. And this also came to me after I got reports where then I'm stuck. I don't know what to do. Then I realized it's better to put in that effort before rather than, talking to all the people after the report is in hand.
Big hospitals like yours, Bindu, will have a tumor board. And you have a wonderful Bharat Cancer Hospital in Mysore, where they give quite good comprehensive. I have referred many patients there. So I think you should keep those people also in the loop. No harm, there's no question of ego here. And 31-year-old has a life-threatening thing and malignancy. Any malignancy to orbit, maximum you write it down. If there's no proper treatment, it's not even 6 months. Life expectancy is not even 6 months. Orbital malignancy.
Yes, ma'am.
Dr. Shiva, are you there?
Dr.
Or you are seeing patients?
Yes,
Dr.
sir.
Bindu, no. I stopped. My OPD is over. Yeah. And Dr. Bindu, you come from Mysore Medical College.
No, sir. No. I'm from JSS Medical College.
Sorry, JSS Medical College.
Yes.
Mysore, right?
Yes.
Yeah. We should appreciate your courage. In a medical college, you have tried to do something which is not possible in other medical colleges. There is a lot of things. You don't have a setup. The seniors will tell you, refer the case. So definitely, I appreciate your courage that you have done a good thing in a medical college, because all these things have to be done in a setup where you have all oncologists, radiation therapists, and a dedicated pathologist. So we should appreciate, as an oculoplasty surgeon, I'll appreciate your courage.
Yes. Thank you, sir.
Yeah. And Orbit is a Pandora box, as my seniors used to tell. You go on searching, you get many rarest of rare things. This is a very rare case. The other case was also a rare case to me. And whatever you have done is a good thing. You have taken an opinion from other pathologists and try to establish the diagnosis, isn't it? That's very important. And anyway, congratulations about this case and for your career also. Thank you.
Thank you, sir. Thank you.
Bindu, are you a member of the Oculoplasty group? one or two?
Yes, ma'am. Yes, I'm there.
Please post the follow-up of this interesting case. It
Yes,
will be
ma'am.
very, very helpful because
Yes.
the small cell carcinomas for lung metastasis itself is rare. And
Yeah.
having like this and in a young patient, what's happening? Did he by any chance get COVID?
No, ma'am. No history of COVID. No.
Okay. Thank you so much.
Thank you, ma'am.
So with this, we come to end of all 4 case presentation. I would thank all the presenters, very interesting cases, not so common. And, really we had to think over and, thanks for stimulating everyone's brain. Only one line I would add just as a take home message, we are just seeing the patients as the way you are presenting. So, whatever we could see, we were trying to discuss on those things. There was no pointer towards your management or towards your case or why this thing is there or not. So whatever data was shared, we were trying to learn from that. So that's the only thing. And, please present,
of course,
share
we
these
learn
cases.
from every case. Most of you who are not members, or if any of you are not members, please become members and contribute, because everybody learns from everything. There's no question that you have learned anything. And now we are going to see an entire new set of problems because of COVID, especially the so-called what we call as pseudotumors or orbital inflammation. It's so different in those who have had vaccines, who have not had vaccine, those who have had the infection, who have not had the infection. We are redefining a new set of orbital pathologies in the long run due to COVID.
So if you are not member of OPI, I would say the first step would be at this session. If you are interested in plasty, please join OPI. It's a great organization to be part of it. And you can also come and join the few WhatsApp groups which are there. If you post anything, the first person to respond to you would be Dr. Lakshmi. She's really active on the WhatsApp discussion group. We are not so much, but one thing about Madam is you can directly call her up to discuss any of the cases and she'll be really helpful. And same goes with all the colleagues. So actually all the people whom I see, the 11 people who are there, I think so one-to-one, you can pick up phone and anyone can discuss with anyone. This is a very, very friendly group of plastic surgeons who are there and who are in Bangalore and Karnataka and who are in this session. So we do have time left. 18 minutes are there. May I request anyone who is on the panel? I can see Raghuraj, Dr. Shantanu, Roshni, Dr. Bindu is there. Would you like to add something to all these cases, or would you like to discuss something which we have missed on a particular case? Raghu, any comments here? Dr. Raghuraj? Either driving or seeing patients. Dr. Shantanu, anything would you like to add, please? Okay.
Yes.
Please go ahead.
Good evening, everyone. Actually, I'm doing my fellowship. I'm about to complete my fellowship in January. Now, I was looking at some of the presentations. Now, till what age can we continue using these conformers and hydrogel expanders, like in congenital anophthalmos?
Till you get an adequate socket, or till your aim of volume, the expansion is there. So a typical thing would be, as you are increasing the size of conformer, the once you are reaching size of 24 or 26, that's the time when you're looking at it. So the endpoint will be as normal as possible. And a normal socket would retain a conformer which is 26 millimeter or 20 even larger. So that's there somewhere. You're starting typically from 12 or 14 mm and you are slowly progressing as much as you can go. And the endpoint to me would be a point where the conformer size does not increase any further. Initially your changes will be much frequent.
Children, it will stop short at around 20.
Yeah. So
Sometimes
if you can even go for
children, 22, 26 little adults.
Yeah. So the large conformer will not really, you'll be able to change. So it will be there with the same size for quite some time, 3-6 months. So that's where you know that, okay, the horizontal expansion, whatever had to be with the conformer has been attained.
Okay.
But the only key point there is, the patient should be having conformer continuously. So that is one instruction and which was seen. So what happens is you tell patient, okay, this conformer is there, now come back after a month or two, whatever way. And that conformer will pop out and they'll come back to you and there is no conformer and you have to start again. So, if they stop wearing that conformer in the initial stages, you are back to ground zero. So that's the only thing that, just make sure that whatever follow-ups are there, their conformer stays in place.
Generally,
Shiva?
by 6 months, we should be, or 7 months, we should be able to give, or even earlier. I think I've given the first shell by 4 months or so.
Even
The
earlier, madam,
diameter,
have
we
been able
measure
to-
it by the diameter, that is a colored shell. So maybe the smallest diameter is around 10 or 12 millimeters, as you said.
The
Correct,
ready-made
12
will be 14,
millimeters.
madam. So what we do
12
is,
also.
yeah. So because it's we have a lab, so we make a smaller one. So you can
that is
actually
good.
make a flat
That's a good
conformer
idea.
with a a clear PMMA, and that we can change frequently. The smallest what I've used, probably Shiva would have seen that also in Arvind. The iris button, what we put in a custom-made prosthesis, the diameter is about 11 to 12 millimeters. So in the patient where it was the smallest child, I could only fit in the round iris, the iris which we use in an ophthalmic socket, with a disc of only 12 millimeters. And later on keep increasing. I would typically, if I'm doing this, I would call them every month, if possible, and if they can come, if they're in Bangalore or in and around, I would keep a little, short follow-up with these patients just to see how they progress.
And sir, if I can, hello.
Yeah, please go ahead.
Yes, sir. Sir, that last case where it was a suspected metastasis to the orbit, wasn't there any clinical history what the loss of weight or anything, or this proptosis was the primary presentation? Like this was the first presentation, like the last presentation. Yes, sir.
I think so. Dr. Bindu has to answer that question. Dr. Bindu, if you are there, any history of weight loss in that patient?
No, sir, no history of weight loss.
Okay, so no, nothing else. But one last thing would be, we had 4 presenters and they all were prepared for this. Would you like to add to others' discussion? Because we have heard from everyone except for the presenters. They have been only answering our questions. So, all 4 presenters, would you like to comment on the other cases or, really add to other cases from your side? Anything you feel? Dr. Shefali, I can see you are there.
Yeah, hi. Yes, sir. No comment, sir. Just thanks a lot, Dr. Roshni and Dr. Ellen for the one.
Dr. Shefali, would you like to?
I think it's dinner time, Gagan. You should leave.
Okay, chalo. It's 13 minutes. If there's nothing else, let's call it dinner.
I'm just joking.
Yeah, okay. Good night to everyone. Thank you so much,
thank you,
Roshni,
Shiva.
Karnataka.
Yeah, thank you. Bye-bye.
Society, everyone. Shivayogi and Gagan.
Thank you,
Thank
everyone.
you. Thank you.
Thanks, Roshmi. And
Shiva is
thanks,
definitely hungry
Shiva.
and he's in his clinic. How far is your home, man?
No, it's upstairs. Come
Yeah.
home once.
Sure.
Yeah.
Just we thought everything
Just
is
a
normal.
5-hour drive. Just 5 hours drive.
Less than that,
No,
madam.
3.5.
3.5 to 4 hours. We are there. And Shiva will definitely give us nice benne dosa. He gets that for everyone who goes there.
Oh, wonderful.
Obviously, of course.
Sure. Thank you, everyone.
Bye. Good night.
We'll follow the
Thanks and
session.
bye. Good night, everyone.
Thank you,
so much.
doctor.
And
Good night.
special
Thank you.
thanks to the 4 presenters in this session.
Yes.
Thank you, ma'am.
Thank you, sir.
Thank
Bye-bye,
you, ma'am.
bye-bye.
Thank you.
Take care. Bye.
Thank you, sir.